So we'll begin with an overview, much like we did with the shoulder. We're going to discuss the protocol, how we look at these. Next, we'll move on to anatomy and search patterns in terms of MRI of the knee, and then really focus on ligaments and meniscus, as well as the extensor mechanism, and then we'll touch on cartilage and miscellaneous findings. So first, we'll discuss the protocol. We'll typically do sagittal PD, sagittal T2, coronal PD, coronal T2, and axial T2 fat-suppressed imaging. We'll touch on the anatomy and the search pattern. Again, what we like to do is start with the sagittal imaging. We'll have both the fat and fluid-sensitive sagittal imaging up on the screen. We'll scroll through them simultaneously. And you can see on the sagittal how nicely we get a view of the anterior cruciate ligament, the posterior cruciate ligament, the medial and lateral menisci, the extensor mechanism, as well as the bones and cartilage. Now, as we move on to the coronal sequences, we get a very nice appreciation for the supporting structures, specifically the medial collateral ligament and the lateral collateral ligament. And the lateral collateral ligament will be more of a ligamentous structure, starting anteriorly with the IT band, onto the lateral collateral ligament, and then more posteriorly the conjoint tendon, the contribution of both the biceps femoris and the lateral collateral ligament. You can see we get a very nice view of the menisci as well as the osseous structures, the distal femur and the proximal tibia. In terms of the axial anatomy, this will very nicely profile the patellofemoral joint. So most of our entities involving the patellofemoral joint, such as transient dislocations, perhaps focal areas of articular cartilage loss, plica, and things like that, will all be best seen on axial MR imaging. We'll also look at menisci and look for fluid collections and or intra-articular bodies. We may also see pop cysts and or strains of the gastroc musculature. Moving on to the ligaments, this is an example of the first ligament tear that we're going to describe, and probably the most common ligamentous tear that you'll see in clinical practice. This is a complete tear of the anterior cruciate ligament. You can see here the disorganization of the fibers. These fibers should normally be low signal in all sequences, paralleling Blumenstadt's line here. There should not be edema within the intercondylar notch. There will frequently be a large associated knee joint effusion. People will describe that their knee swells up like a basketball very soon or immediately after the injury. And again, you can, on a more chronic basis, you may not be presented with something like this, but you may see discontinuity between the fibers and some resolution of the intercondylar edema. We see a lot of these this time of the year with ski season, and so just be aware that you will see these. These are increasing in terms of both the diagnosis as well as the patients coming for imaging. So moving on to primary signs, we described some of these: non-visualization, discontinuity of the fibers, edema in that intercondylar notch, and a large knee joint effusion. But I think what's most helpful with these ACL tears are some of these secondary signs. So there's always those cases where you're just kind of not sure, you're going back and forth. Is that the normal anteromedial and posterolateral bundle with fluid insinuating through it? Is there some abnormal mucoid degeneration, which is limiting evaluation? And so you can use some of these secondary findings to really help you and really seal the diagnosis in questionable cases. One is going to be this bone bruise, right? And it's going to be a classic kissing contusions on the lateral side of the knee. Second would be, as a result of this, deepening of that lateral femoral notch, greater than about 2 millimeters, either on x-rays or MRI. Next, you may see something like a Sagan fracture and a avulsion injury of that lateral capsular ligament. You may see PCL buckling, anterior tibial translation as well. Here's an example. So when these patients come in, they describe of a dynamic injury where they suddenly felt either a pop or a shift in their knee, and then were suddenly unstable. And so this has been described by the orthopedic literature as a dynamic valgus moment or a pivot shift mechanism of injury. And you can see what happens here is as the tibia translates anteriorly, it will knock into the distal femur, and this results in a characteristic injury pattern, either an impaction fracture or at the very least a bone contusion at this condylopatellar sulcus. And this is all on the lateral side of the joint, denoted here by the proximal fibula. As a result, by the time they come to imaging and we see them, we're going to see a bone contusion pattern, something like this, where there's edema at the posterior aspect of the lateral tibia and edema at the condylopatellar sulcus of the femur. Here's an MR example, fluid sensitive, demonstrating edema, again, in the condylopatellar sulcus, as well as the posterior aspect of that tibial plateau. Now, this is on the medial side of the joint, and there may also be edema posteriorly on the medial side of the joint. This has been shown to portend a worse prognosis or a longer recovery time, so I think it's something that is absolutely worth mentioning in our reports, but also understanding the value of mentioning it, in that our surgical colleagues will understand that this injury pattern was perhaps more severe than some of the other ACL injuries. Other associated findings now as a result of this contusion pattern will be, because of the impaction in this region, deepening of that lateral femoral condylar notch right in this area where the tibia has indented that condylopatellar sulcus. We may also see avulsion fractures, and the avulsion fractures are typically going to be seen either in one of two ways. One, in an adult patient, we'll see something like this, an avulsion fracture of that lateral capsular ligament, a Sagan fracture, again, very suggestive of an ACL tear. In children, however, you may see something more like this, where there's an avulsion injury at the tibial spine. In children, their bones are frequently weaker than their tendons, so they will tear off the tibial spine rather than having a complete tear of their anterior cruciate ligament. These are much easier to repair and or heal because it is a bone-to-bone healing rather than in adults where we do bone-tendon graft reconstruction. Because this was an anterior translational phenomenon, we then may see anterior tibial translation resultantly. And the way we define that is when we draw a line posterior to the lateral femoral condyle, this should intersect the posterior third of that tibia. And if it does not, we will diagnose anterior tibial translation. In terms of a few postoperative cases now, so these are patients who've had ACL tear, ACL graft reconstruction, and then are presenting to you again. And just given how common this has become, how frequently ACLs are injured, we're increasingly seeing these post-op at the very first time in our practice. So I just wanted to go through some of the findings that we should be looking for in this specific subpopulation. One is you want to look for a cyclops lesion. Now, a cyclops lesion is seen here on the sagittal fluid-sensitive MR as a rounded area of low signal. It'll be low signal on all sequences. And what this is, in fact, is scarring and fibrosis surrounding the distal stump of the torn ACL. When our surgical colleagues go in and repair the ACL, they do not remove the distal stump of the ACL. So this is frequently left and oftentimes will go on to scarring and or the cyclops lesion. This is distinct from arthrofibrosis, right? Arthrofibrosis simply refers to scarring in the anterior aspect of either Hoffa's fat pad or in the anterior soft tissues. It's not within the joint space itself. So we use arthrofibrosis to describe normal post-surgical scarring within the soft tissues or the fat pad, and cyclops to really describe this focal lesion in the anterior aspect of the intercondylar notch. And pathologic studies have shown ACL remnant fibers within these lesions when surgically resected. These are important to resect because they can present with clicking and locking, and just like anything else within the knee, a body, a meniscal fragment, or anything like that. This is what our surgical colleagues see at the time of arthroscopy. You could imagine a surgeon putting in a probe here anteriorly and immediately having this eye facing him, and this is the nomenclature for the cyclops lesion. Other findings that we may see are these peritunnel cysts. These will widen the tunnels and can result in laxity of the graft and may lead on occasion to extension of these into the soft tissues anteriorly. So just be aware and describe these when present. You may also see something like this. This is not very common, but when you do see it, it can be quite drastic, where we see a significant amount of bone marrow edema on this coronal fluid-sensitive MR and really substantiated on this sagittal fluid-sensitive MR. And we can see right around that proximal screw, there's not only edema, but there's also a fracture through that proximal screw. And for all the world, this looks like something that's infected, right? So the differential here would absolutely be something like infection But in the back of your mind, keep in mind foreign body reactions. Foreign body reactions, again, while rare, won't typically have intraosseous fluid. They won't typically decompress into abscesses in the surrounding soft tissues. So when you see something like this, just remember to have a differential, foreign body reaction and or infection. Here's a case of infection. Infection will instead, especially as it advances and progresses, will have more fluid collections within the bone itself, and it may even decompress into the surrounding soft tissues, seen here on the post-contrast study with an abscess peripherally. Other examples of hardware failure, again, rare, but we're seeing these increasingly in our practice. We may have something like this, where the bone plug is dislodged from the distal tibial screw. You may have fractures of the crosspin, as seen here, where the crosspin has even been centralized into the intercondylar notch. And very unusual case where you had a fractured crosspin, some of which went into the intercondylar notch, and some of which migrated laterally and was resulting in an iliotibial band friction type syndrome clinically. In terms of the PCL, injuries to the PCL are going to be much, much, much less common than ACL injuries. They're typically going to be due to posterior translation of the tibia rather than anterior translation. And really the only force, or one of the most common forces that will result in this type of an injury, is going to be an MVA. As the patient is seated, the dashboard may impact the proximal tibia, and in this area result in posterior translation of the tibia relative to the femur and tear of that PCL. Now, most of these are also not as significant to our surgical colleagues. Even for complete PCL tears, in most patients, they will put a brace or result in some sort of conservative management. The exception being if it's a multi-ligamentous injury where the ACL, PCL, MCL, and many other ligaments are torn. In those cases, they will go ahead and on occasion repair the PCL as well. Much like the ACL, the findings are going to be edema, frank discontinuity of the ligament, and an associated joint effusion. Moving on to the medial and lateral supporting structures, we'll start with the MCL. The MCL should be a normal black structure, low signal in all sequences, very thin, and you can see here complete disruption of this medial collateral ligament proximally. This is what the proximal fibers should look like normally, and then you can appreciate here distally, again, just complete discontinuity of the distal medial collateral ligamentous fibers. The way that these have been graded is all based, again, on the surgical literature. So when we describe this, we'll either describe 1, edema tracking superficial to the ligament, just within the soft tissues. 2, we'll describe edema superficial and deep. That suggests associated injury of not only the superficial portions of the MCL, but also the deep portions of the MCL, or a grade 3 sprain where there is complete tear of that ligament. In terms of the lateral ligamentous structures, we saw this a little bit at the beginning of the talk with the anatomy from anterior to posterior. First, the IT band, the fibular collateral ligament, and the biceps femoris tendon. Now, we get a lot of questions about posterolateral corner and posterolateral corner edema and injury, especially in the setting of ACL injuries. And the reason this becomes important is that when you have lateral collateral complex injuries, be it the IT band, the conjoint tendon, and so on, there will frequently be edema in the posterolateral corner. What we will report is that there is edema in that posterolateral corner and that it's suggestive of an injury of the arcuate, popliteofibular, and or popliteus tendon. Now, the only one of these that we can really see well is that popliteus tendon. So we can tell, yes, there is a frank tear, or no, we're sure there is not a tear. For some of these other ones, you may see the popliteofibular on occasion, but when you have edema in the posterolateral corner, I think it suffices to say there is edema. I cannot exclude injury of the arcuate and or popliteofibular ligaments, and that will be quite helpful to the surgeons so that when they go in and they're doing the ACL repair, they at the very least probe this region and identify these ligamentous structures and repair them if needed. This is an example of a lateral collateral ligamentous complex injury. You can see the conjoint tendon is no longer inserting laterally. There is associated hematoma, and we could not exclude posterolateral corner injury in a case like this. Moving on to menisci. So we've talked about our protocol, the anatomy, how we go through our imaging search. We've discussed the ACL and the PCL, as well as the surrounding structures, the medial supporting structures and the lateral supporting structures. And we'll spend the most of the remainder of this talk on the menisci. Now, I think this slide is really the most helpful for meniscal tears and what is a tear and what is not a tear. And you can see here the meniscus is always going to be triangular, especially on sagittal imaging. And if we see any abnormal signal within the substance of the meniscus, whether it's round or linear, we're going to describe that as intersubstance degeneration. What we need to call a frank tear of the meniscus is going to be linear signal violating a meniscal or articular surface. And we'll go through the different types. For all practical purposes, the way that we characterize these are either going to be longitudinal, a bucket handle type tear, or a radial tear. There are many different ways to categorize meniscal tears. There are different classifications in the literature, but this is what we used when I was a fellow at UC San Diego. This is what we use at UCSF, and I think this is completely adequate for our surgeons. They seem very happy with it, and I think a lot of the other classifications only serve to make things more confusing. So let's simplify it and really focus on these three types of tears. First is going to be a longitudinal tear. Now, a longitudinal tear is going to be what we see most commonly, and it will either be horizontal or vertical, and I'll show you what I mean with specific cases. The second type of tear is going to be a bucket handle tear. A bucket handle tear is typically seen in young people and will result in a flap of the free edge of the meniscus extending into the intercondylar notch, and we'll see cases of that as well. Lastly, you may see a radial tear. A radial tear is very different than all of the other tears. It's one that doesn't really extend superior, inferior. It's one that's instead extending centrally to peripherally. So it's very different. It's very nicely seen on axial images when you're lucky enough to see it, and I'll show you examples of that. If this does then course along the fibers of the meniscus in this direction, a radial tear, that's been given the name a parrot beak tear. But let's start with the longitudinal horizontal oblique tear. This is what we see most commonly. You can see in the posterior horn of the medial meniscus, there is longitudinally oriented fluid intensity signal, and it's violating to an articular surface. Now, this could violate the superior meniscal surface, the inferior meniscal surface, or the peripheral meniscal surface. In any case, this is a longitudinal horizontal type tear. This is what it may look like to our arthroscopic colleagues, but again, a longitudinal horizontal type tear on arthroscopy. This is very different than a longitudinal vertical tear. A longitudinal vertical tear will, on sagittal imaging, be in the vertical plane and will often violate both the superior and inferior meniscal surfaces. Okay, moving on. So from longitudinal obliques, both horizontal and vertical, now to our second type of meniscal tears, the bucket handle type tear. These are there's a lot of attention paid to these bucket handle tears, and there's a couple reasons for that. One is that they're frequently seen on a traumatic basis. So what does that mean? They're seen in young, healthy, active individuals, a lot of times in association with ACL tears and other internal derangements of the joint. The inner edge will be displaced into the notch, and this is what's referred to as that handle, the bucket handle. And if diagnosed early, the vascular interface of this can be repaired. So rather than having to resect this huge piece of meniscal normal tissue that's just been torn off the remainder of the meniscal tissue, this can be repaired. And that's really critical, and why we pick up a phone and talk to the surgeon when we see something like this, so they can bring them in for surgery sooner. In terms of how this may look for us on imaging, one, we may see something like this, the double PCL sign, where the large flap has been displaced into the intercondylar notch. We may see something like this, where we see a big fragment of that torn meniscus in the notch here on a cone down coronal sequence. But I really love the axial images for these types of tears. And if you look here, really everything just kind of makes sense, where you have this large bucket handle fragment that's torn away from the rest of the meniscus. It looks like a very diminutive meniscus otherwise, and now it's lying in the intercondylar notch. It makes sense that on other planes this would result in either a double anterior horn, a double PCL, and just for orientation purposes, I find this very helpful. Here's an example of that double anterior horn sign, where we have the normal meniscus and the flipped fragment. And now moving on to our last type, this radial type tear. Again, remember, this is different than a vertical longitudinal, because it's not extending superiorly to inferiorly. It's rather extending centrally to peripherally, from the articular surface peripherally. And so what you may see on an axial image is something like this, again, extending centrally to peripherally. It's a tear from that central free edge. It's about 15% of tears, but it's a very specific subset of tears. It's typically seen in older patients on a degenerative basis, and it will result in this kind of constellation of findings subsequently. One being peripheral extrusion of that meniscus, maceration of that meniscus, which will result in articular cartilage being destroyed over time, and eventually subjacent bone marrow edema, perhaps a bone fracture, and those are the patients who then go on to total knee replacement. What this may look like, given how small this tear is very subtle findings on the coronal and sagittal MR sequences. Here's a sagittal MR. You can see just a very small cleft that is absent that would be very hard to identify if you're going through this quite quickly. Secondly, coronal is going to be very, very helpful. One, you can see the truncated triangle, which is another finding specifically on coronal, but you also see some of this peripheral extrusion, which should at least alert you to the fact that there may be a radial tear. And last, if you image this just right and the radial tear is posteriorly, you may see something like this, where you don't even see the posterior horn of that meniscus, or what's termed a ghost meniscus. Now, we may see perimeniscal cysts, just like in the labrum. Those should alert us to meniscal tears, and these can be treated with ultrasound. I've included some slides here on the extensor mechanism, the quadriceps, and the patellar tendons in your syllabus, and just to kind of show you a couple of cases of tendon ruptures. But I want you to have a differential for tendon ruptures. You know, typically these were seen in traumatic cases, patients who had a specific injury and then came in with a tear. And that is still the most common, but increasingly we're seeing patients with either chronic renal failure, metabolic processes like diabetes, steroid use, in chronic inflammatory processes, be it crystal deposition or otherwise, as well as antibiotic use, such as with fluoroquinolones, having a predisposition for tendon rupture. So you may be seeing this more commonly, and this differential will help you in cases where there really was no antecedent trauma. In terms of cartilage, we will grade these as 1 of 4, 1 being kind of some signal heterogeneity. You can see this is a normal example of what the cartilage should look like, kind of gray, no areas of signal heterogeneity, no areas of fissuring, or any full thickness chondral defects. We'll call it a grade 2 when we do see some low-grade fissuring, a 3 when there is moderate-grade fissuring, or in something like this would be a focal, full-thickness chondral defect right at that median ridge lateral facet junction. This is helpful to our surgical colleagues because they will increasingly go in and do cartilage replacing procedures, be it a microfracture type surgery or an osteochondral implantation. All right. Here's another kind of companion case where we have a plica, and we see these very frequently, these medial plica, and there is an associated full thickness fissure now, and when you see this constellation of findings, it's helpful to our surgeons because they will go in and oftentimes resect this plica that's resulting in this full thickness chondral defect, either in isolation or in conjunction with other abnormalities. So it's something that we do include in our report and is helpful to our clinical colleagues. A couple of miscellaneous findings again. Tibial plateau fractures, especially non-displaced ones, can be quite subtle on initial x-rays. The patients will continue to manifest pain, and so this would not be a diagnostic dilemma on MR. We can see linear areas of low T1 signal consistent with a tear, but remember CT is going to be the study of choice, and the Schatzker classification for these lateral plateau fractures is going to be made on CT. We may also see popliteal cysts. Remember that these will arise between the medial head of the gastroc and the semimembranosus, and increasingly we're being asked to do ultrasound-guided aspirations and steroid injections of these popliteal cysts for symptomatic relief.